This is what we're going to do. Basic introduction to the machine, the different kind of probes you can get, and the ones that I'm going to concentrate on today are purely for musculoskeletal. There are other probes that you can get which are good for MSK. There are curvy linear probes that are good for scanning the viscera. Our focus today is musculoskeletal. We're just going to have a look at a certain type of probe today. If you have a device, you may have something like this, which is a laptop scanner. And if we go back a couple of slides and have a look at this one, this is a cart-based model, and they're very similar in their structure. It's just that you've got more space for certain things. On the laptop version, the control panel is built into the machine, and the monitor is just like a laptop, is attached to it as well. The buttons on there are very, very similar. You've just got a little bit more room. Then there are handheld scanners these days as well, portable scanners. There's lots for you to choose from. In clinic, I use a laptop scanner, and you're going to see some videos of the one that I use. I got mine from Celtic about 5 years ago. So yeah, it's been a while. Seeing the new scanners come through, really tempted to get an upgrade because you realize how far the technology's come on even in just 5 years. This is the probe that we recommend using for MSK. They come in different widths. My probe I was using, is it the X11, the new one, Rich? Is that the one that I had a play with the other day?
The X11 is the
X11,
newest
yeah. So
one.
that had quite a wide probe on it, and my old S9 is a little bit slimmer. So they do come with different probe widths, but you can also get hockey stick scanners for small joints around the foot and ankle, really good for that, and also around the wrist. But that probe there is good for most musculoskeletal presentations. You can get good images of the foot and ankle with something like this as well. You don't have to have the hockey stick. It depends on what you specialize in and which probe will be best for you. Obviously, you're going to need to take shares out in ultrasound gel when you start doing scanning. We use a lot of gel. If you don't have enough gel, you don't get a good image. And it's one of the really common mistakes that you see people make. When they start scanning and you see an image, it has a big black line down the image, and it's because there's no contact with the gel, which is then not transmitting the ultrasound into the skin. If your images aren't great, that's probably one of your first things to have a look at is, do you actually have enough gel? And the problem with gel when it's kept at room temperature is it gets really runny. It runs off the skin. When you're imaging, it will get quite thin, especially if you're moving around an area. It kind of dries up fairly quickly or runs off. My patients love it. I do warn them beforehand, but I make sure that mine are in the fridge so that it keeps the gel nice and cold, and then it stays in place as well. It's good for me, a little bit of a shock sometimes for them, but I get a much better image when it's colder gel. And I know some people use gel warmers in their clinic, but literally the gel will just run off if you use one of those. It is best to keep it at least room temperature, but if you can keep it a little bit chilled, then that's a good idea as well. This is what you should see with this kind of probe, or linear probe. This is the kind of image that you get. The very top part of the screen is the skin, the superficial tissue, and then just underneath that we've got the subcutaneous fat layer. What we're seeing, it's like, I don't know whether you remember at school, you had the boats that came across the top of the sea, and then they'd send a sonar signal down to the seabed, which would then bounce back up again into the boat, and then it would generate an image of the seabed beneath. And that's basically what we're doing here with a scanner. We're sending ultrasound down through the tissue, and depending on what tissue it hits, the kind of integrity of the tissue, the consistency of the tissue, you'll get a different image come back. The processor within the kit works out from the bounce back what kind of image that it should show you on the screen. It's basically just trying to make something out of the information, like the ones and zeros that is coming back to it. And that's why we get the different images that we do. I'm going to talk a little bit about the differences in some of the tissue, but you can kind of see it here anyway on this image. Muscle is quite dark, with speckledy bits in. And if you remember back to the anatomy textbooks, you had the myofibrils, those muscle fibers wrapped in connective tissue, and then they were wrapped in bundles, which then were wrapped in connective tissue. And then those bundles then also were wrapped in connective tissue. Each of those fascial layers you can see, and depending on the thickness, you'll see them brighter or a little bit less bright if there's not very much of that tissue. With a muscle, it looks a bit like a marbled steak. Yeah, and then on the edge of the muscle, you've got the fascial layer, which is a little bit thicker in that area. That fascia, because it's a bit denser, it bounces back more light, so it looks bright. The brightest thing that you'll see is the bone. It can't pass through bone, it can't penetrate through bone. When the ultrasound bounces back to the probe and then the machine works out what it is, it makes it really bright because of the way that it comes back. Brighter stuff like this area here and this area here, this is connective tissue. The little flecks of white in there, that's connective tissue as well. And this layer here, which is subcutaneous fat, it's kind of globular. It's basically pockets of fat cells all next to each other. And again, when you look on cadavers and you peel back the skin, you can see all of the yellow fat. That's basically what this is here. It's the globules of fat that you can see. And around this area here, if you had something like a lipoma, that's where it would be, is in that subcutaneous space. It's fairly standard to get that layering on most imaging, but obviously it depends where you're scanning. When we're scanning, we can get mistakes because the machine is trying to work out what the tissue is underneath based on the signals coming back to the probe. It's basically generating that image within the processor. Sometimes the information that's received, the processor makes stuff up to try and fill in what it thinks is there. We then need to use our clinical knowledge as well to work out, is this real or is this an artifact? Is it something that the machine has made up to make it look, to try and fill in the gaps of the information it's receiving? And one of the key things that are a problem is when we're scanning tendons, if you haven't quite got enough gel or the angle is not quite right on the particular structure, it will look dark, it will look black, and it will look as if there's a tear in the tendon. But if you slightly reorientate your probe, or you put a little bit more gel on, or you push down into the skin a little bit more, you can fill in the gap often, quite often, unless there is actually a tear there. One of your first jobs is to work out, is this real or not? And that can be quite disconcerting when you first start, because obviously you're just trying it out and you think that there's a lot of issues with people's tissue, but actually it's you as an operator haven't either got the right angle or the settings quite right on the machine. So that's what we're going to have a look at to make sure you get the right thing. When we're looking at different structures, we call the different brightness of objects various different echoes. We've got areas that are hypoechoic. If we have a look down here, hypoechoic is a structure with very few echoes and appears darker than surrounding tissues, this area around here. Then we've got anechoic. Anechoic is no colour at all, so it's completely black. You can see that area there is anechoic. And then we've got hyperechoic, which is this area here, which is an elevated level of brightness on a specific structure. And different tissues will give you these properties back on the screen when you scan them. Anechoic areas are usually fluid-filled spaces. A cyst would be black, completely black. If there was edema, it would be black. If there was blood, it would be black. Yeah, so vessels are black. If there's a calcification in a tendon, it would be white, or it'd be whiter than the surrounding tissue, so it'd be more hyperechoic. And you can work out what structures are what depending on what images that you're seeing. Anything black, usually there's a gap, there's a hole or a tear, or if there's some kind of fluid in that area. Now, one thing we're not going to cover today, I won't have time today, but something that you could look into is something called Doppler. And with Doppler scanning, you can check flow of areas. So you can see if there's a vessel nearby. Let's say there's a tube of black next to something. You go, is that swelling or is that a vessel? If you put Doppler on it, you'll see the flow of the blood. So you'll know that it's a vessel. But if it's completely silent on Doppler, then it's still fluid. There's no flow to it. But inflammation, if there's an acute inflammatory response to an area, it will be dappled and you'll get red and blue little spots light up on the screen, and you'll know that there's an inflammatory process taking place over that tissue. That's something that you can look out for as well if you've got dark areas that are anechoic. Then we've got these kind of artifacts. Some of them can help you work out what's going on. Some of them can be a bit confusing. One of the things that is an artifact is shadowing. So remember I just said black is usually fluid. Well, black is also, I can't see behind it because it's blocked. For example, like this one, this is a gallstone. You can see the stone here, but then because the ultrasound can't pass through the calcification, it appears as if there's a hole in the structure underneath the stone. And it's because the ultrasound literally can't pass through, so it comes back as black. That would be an artifact. Hopefully that makes sense. And you'll see these with calcification. If it's in a supraspinatus or an Achilles, you'll see little pockets of black underneath where the calcifications are because the ultrasound can't pass through. Okay? If it's a fluid, ultrasound is enhanced whenever there's a liquid. If I have something like a cyst here, a fluid-filled cyst, as the ultrasound is passing through, it will intensify that ultrasound as it's passing through. It will make the structures behind the fluid appear really bright. And that is really useful because then we go, right, that is most likely a fluid because of what's happening underneath, like in this image here. We've got an area that's full of fluid, pass ultrasound through, and then it's brighter underneath. We get what's called an acoustic enhancement in that area. We can use these anomalies to help us. This one's an interesting one. If you are using injection therapy and you want to do ultrasound guided injections, there is a specific setting on the machines that tells the machine that you're using a needle. Because if you have a metal object in the skin as you're scanning it, it doesn't really understand what the object is. It doesn't really compute with the processor. You get this reverberation effect unless you switch the settings to a needle setting, and then you'll see the needle really clearly. This happened with someone that I know where they did a scan on someone who years ago when they were a kid, they fell onto like a wire fence, and they didn't realize, but they still had a bit of the wire fence in their leg. About 20 years later, they'd had this scan, and when they scanned it, it was reverberating like this, and it was because of the metal that was still in the tissue. And they were like, what the heck is that? And then they realized that talking through their history, that that's what it was. Anything metal will reverberate and you'll get this rebound kind of signal sent back to the machine. Now, this one is a real classic operator error. It's called anisotropy, and it's usually a property of tendons or muscles. And what will happen is the ultrasound will vary depending on the angle that the ultrasound is delivered. Ultrasound works straight down, straight up. It will hit whatever it is and then it will bounce straight back up again. If you're hitting curved objects, then the ultrasound can ping off in different directions. Sometimes there'll be gaps in the image. This image here is of a supraspinatus tendon, and you can see this area here is very dark, and it's because of the curve of the bone and the curve of the tendon. But if you move the limb or you move the probe slightly so that you align those ultrasound beams a little bit better, it fills in the gap, and then you realize it's not a tear, it was actually just operator error. That's one of the first checks that you need to do when you very first start scanning. This is called a longitudinal view. When you look along fibers, you'll get a lengthways view of the tissue. If you can see a tear in lengthways, it should also be there in a short view, in a cross-sectional view as well. If it's there in one, but not the other, it's probably that you've made a mistake on the first one. You need to go and check it again. If it's there on both, then it's very likely that they have an injury to that area. You'd need to check it on both views. This is a way that you can manipulate your probe. And when you very first start, one of the first areas that I teach when we do the face-to-face training is just on a finger, because it's really easy to scan. We can kind of visualize what a finger looks like underneath the skin. And what you can do is you can try out all of these different probe techniques. They seem very simple, but the body isn't in straight lines. The bones are curved, they're rounded. Sometimes you get a beautiful image on one part of the picture, but then on the other part of it, because the probe is slightly off the bone, you've got black and you can't see anything. And then you move it to try and get the other part in line, and then you've moved the other bit that you had a good image on. It's a bit of a cat and mouse game when you very first start. But if you have a look at some of these movements, we've got a sliding movement. That's a good one to slide up and down the bone, and you try and keep the bone really bright on the finger as you go up and down. That'll be a long view. And then if you switch the probe around so it's lengthways like that, then you can get a cross-sectional view as well, and you slide up and down. You can practice these probe handling skills, all of these, on fingers really easily. Heel toe action, because the bone is curved. So there'll be elements of the finger where you can see it really well because it's in line with the probe. But then if you tilt it slightly, tilt the probe slightly, you'll see better the curve on the other bit of the bone. And by heel toeing it side to side, you get a really good image then of both aspects of the finger. D is a compression, so that's where you just push down. If you've got a cyst, so say it's a ganglion cyst in the wrist, and you think it's fluid filled, but you're not really sure. If you compress it and push it with the probe, it will squish. The fluid that's in it will get squashed, and then it will pop back up again. You can tell from the sonopalpation, so palpating with the probe, and you can see it moving as you're doing it. If it was something solid, it wouldn't move and it wouldn't change. So you can use compression to again confirm or deny whatever you think the structure is. These ones where you pivot, these are quite hard techniques to master. My best advice with this when you first start, this one in particular, F, this is good if you're doing a lower limb scan and you're using the, let's say, lateral malleolus for the ATFL. So you get one end of the probe onto the lateral malleolus, and then you can keep that end on the malleolus as you scan through the tissue to try and find the ATFL. But you use that bony landmark as the area where you definitely know, then you can move the probe to try and pick up the other tissue around it. That's a really useful technique around bony landmarks, because you know something is definitely there, and then you can use that landmark to then find other structures. This one here, this is where you use ultrasound gel like a clump on the top of the skin. If you're scanning feet or hands, the tissue is really thin, and if you've got very little ultrasound gel there, then it's really hard to differentiate the structures. If you get your cold gel, because this doesn't really work with warm gel, and you create what's called a standoff, you create this cushion of ultrasound gel and you rest the probe in the gel rather than on the skin. And what that does then is gives you a really, really good image of the superficial tissue, skin level. If you're looking at, say, the, I don't know, extensor digitorum, whatever, they're really, really superficial. So you can use that gel over those tendons, just rest the probe in the top of the gel, and you'll get a really good image of those tendons. If you've got it too close to the skin and with very little gel, it's harder to see. Again, another little tip when you're first starting out. Let me just show you this. I'm going to show you a little video of, again, one of the mistakes that people make when they very first start. This is orientating your screen. I'll just show you this. On your probe, there is a little bump. If I just pause that there, can you see that little bump? So that little elevated area there. That elevated area there, this is on the left-hand side, well, hopefully, as I do it, will correspond with that on this sonoscape. It will correspond with the S here. When I move my probe and I'm scanning something, I want that bump to be aligned with the left side. If I'm looking at the screen and scanning someone at the same time, I want my probe to move. If I move to the left, I want the screen to move in the same direction. Because if it moves the other way, I mean, you can scan that way, but it gets really confusing because it's like scanning in mirror. And I mean, like I say, if your mind works that way, then that's fine. So, say you had a finger there and then you wanted to scan that bit of the finger, you'd have the left hand edge of the probe there. And then if I glide it that way, then the screen would move in that direction. It makes it a heck of a lot easier when you've got things lined up. That bump there corresponds with that there. When I do my scanning videos in a second, I'll show you how I've married things up on the screen so you can see how that works. What we're going to have a look at now is these four key things. So best thing to do when you first try is work on something that you understand the anatomy of really well. And then something easy to scan is an Achilles. They're really simple to scan because you can use the end of the probe on the calcaneus and you can line up. So you can use that pivot technique where you keep the end of the probe on the calcaneus and then you pivot the probe around until you can see the Achilles nicely lined up. It's a really good one to start with. And then once you've got that in position, you can then play around with these things to try and make your image as good as it can possibly be. So frequency and wavelength, you can adjust these so that it adjusts the settings on the probe. Now, different probes have got different frequency settings. And for musculoskeletal, we usually use higher frequency probes because they are better at scanning superficial tissue. If you want to scan viscera, so you want to do abdominal scanning, you're going to need a lower frequency probe because the lower the frequency, the better depth you can get and the deeper structures you can see. The only problem is you compromise some things. So here is a graph of a resolution in green and then penetration depth in, I think that's purple. I'm a bit red-green colorblind, so I think that looks purple to me. Yeah, okay. So we've got a linear probe, which is the MSK probe that I showed you earlier. That's anywhere between 5 and 15 hertz. The hertz is the amount of ultrasound that is sent down and back within 1 second. So 1 hertz would be 1 wavelength a second. 15 is 15 wavelengths in 1 second. You've got a lot of energy, but it's absorbed in the superficial tissue. These ones here, these lower frequency probes, these have got really good penetration depth, so they can get really, really deep here, but the resolution is really poor. You can't see deeper structures very well. But we can tweak things even with a linear probe and play around with the settings. So if you did want to scan something deeper, you can get a fairly good image. If we have a look here, this is at 8 hertz, so quite low frequency. You can see the sciatic nerve just there. Nerves look like a honeycomb type structure. And remember, blood vessels are dark. You can see the popliteal artery there around the back of the knee. So that's on a low frequency setting. If we change it to 10 hertz, we increase the frequency, then it starts to get a little bit clouded. You can't really see much very well. And it's because the frequency is so high that the sound waves can't pass through to the deeper structures. They're absorbed in the superficial tissue. It will give you a very good superficial image, but lower than that, you won't get a very good image. Again, if you've been playing around with your machine and you're like, oh, the images are really dark, that might be why. It's because you've got your frequency setting too low or too high, depending on what you're trying to image. This one here at 12 hertz, where the frequency is quite high, you can barely make, well, you can't really see the popliteal artery at all, and you can barely make out the sciatic. But superficial tissue, you can see that really good. Yeah, that's the difference between the two. If you're going to be scanning MSK and especially lower limb, you're going to need one of these. You're going to need a linear probe and that will sort you out. You'll get some good images with that. Let me just show you how to switch that around. This is how you adjust the frequency on my machine. There are some little dials and buttons near the screens, and you might not have seen these before. You just use the standard settings, but you've got a button there. We'll just go back a little bit. There's a button right there And if you press it, can you see this box here? We've got focal span and frequency. When you press the button, it will toggle between those two options. And then there's also a dial around that button. So when you spin the dial, it will then change whether either a focal span or frequency, depending on what you set up on. And then up here, we've got the frequency there between 9 and 13.8. That's the range of frequency that I've got set up at the moment. If I press that button, change it to frequency, there it is there. And then as I spin the dial, the frequency increases to 11.5 to 14.6. If I'm scanning something superficial, I want it on that higher frequency. Achilles, definitely want it on that higher frequency. That's, like I say, one thing that people often get wrong. The frequency is the wrong setting, so then it messes up your image quality. That's checklist number one. Checklist number two is the depth. On the side of the screen, I'll show you in a second, you've got measurements in centimeters. Now, if you want to scan something superficial, if you have the depth setting too low, what you're doing is you're asking the probe to scan really deep. But if the stuff you want to see is in the top 2 centimeters, the probe is trying to scan down to maybe 6 centimeters, and you're wasting the energy of the ultrasound because it's trying to get that deep. You need to adjust the depth so it comes up to exactly where you want to scan, and then it will focus all of the energy then on that superficial tissue and you'll get a much better image. So if we have a look here, we've got a 4 centimeter depth here, and then as you go down 5, 6, 7 and 8, that tip of that bone is getting really dull, even though the probe is in the same place, just because you've got the depth setting wrong. The bone should be nice and bright, especially if it's superficial, but here it's really dull, you can't see it. The way that you adjust your depth is by doing this. And this is on my machine, it might be slightly different on yours, but they're all much of a muchness. I've got old toggle buttons. So there's the depth on the side there, it's down to 4 centimeters. There's my depth button there. When I toggle that, it will change the screen. There it's down to 2 centimeters, and then it's flicked back down to 4. Again, knowing your anatomy is important because we know that the Achilles is really superficial, so there's no point in going really deep unless you want to see the posterior aspect of the ankle. Yes, if you think there's a posterior impingement problem, you're going to need the depth. But if you just want to focus on the Achilles, then you want to bring that depth up so that the ultrasound focus is just there. Again, a common problem, the depth is wrong. And then the next one, we've got two types of brightness to maximize the a kind of band across the screen or the whole screen at once. And the way that I describe this, I had some people on the course the other day that were in their 20s and they didn't have a clue what I was talking about. I was talking about an old black and white TV and the contrast button, and they didn't understand. They hadn't seen it before. If you're old enough and do remember the contrast button on a black and white TV, then that's what this is like. If you think about the depth of the structures that you want to have a look at, you will have noticed on your device that you've got all of these toggles, all of these buttons here. And if you push the buttons to the right, it will brighten the area that that button relates to on the screen, but only that row. For example, if I wanted to, as I'm scanning the back of the ankle, and I've looked at the Achilles already, but now I want to really highlight, say, Kager's fat pad. What I would do is I would knock the top layer to 0. So I would darken the Achilles, and then I would try to brighten. I push the buttons on the bottom row to the right so that it brightens this column down here where the fat pad would be. If you have a look on this one, we can see these ones have been pushed up really bright. These ones have been pushed really dark. So that area there is dark because it corresponds with those two. The next bit down, this bit, is really bright because that row corresponds to those two buttons, and then underneath it it's dark again. You can ask the machine to focus the brightness on a specific layer of tissue. And again, if you know the anatomy of what is there, then you can really highlight a specific section. So let me just show you that as well. It's called time gain compensation, this one, TGC. And what you'll see is there'll be a straight line down the side of your screen. These are the buttons that are on mine. And on the side of the screen, when you start to play around with these buttons, you'll get these lines come up like that. So as I'm moving the sliders back and forth, it's changing the brightness at different levels of the screen. If I wanted to focus, if I just pause that a second, if I just wanted to focus around this kind of 2 centimeter depth area here, then I would only move the middle toggles over to the, or sliders over to the right. And then if I wanted to blacken everything else, then I'd move the rest of them to the left, and it would literally just highlight that strip of tissue. Again, that's a nice way of being quite specific with where you want the ultrasound to focus on. Then we've got overall gain. This is the old contrast button on the telly. And this is a button where it doesn't just highlight a specific row, it highlights the whole screen. This is a common mistake. Sometimes when I'm teaching the courses, I'll come across and the screen looks really dark and they're struggling to see stuff. And all they need to do is turn the gain up and then it will improve the brightness of the whole screen. But you don't want it too bright though. If it's undergained, it looks like this. If it's overgained, it's just too much. But if you play around with it and it's just right, then it should look something like that. Obviously, everybody's got their own preferences with how bright they want the screen, but have a play around with that gain button to increase or decrease the brightness to get the right image for you. This is how you do that. There's my gain button. And then as I rotate it, hopefully you'll see, there we go. That's brightening up that top bit there, and then it will darken it as it's turned the other way. Turn it clockwise, it'll brighten it. Anti-clockwise will darken it. If the whole screen is too dark, turn up the gain and it should brighten everything up for you. Those are some little tips on how to get a good image. Make sure your frequency is right. Make sure the depth is right to the structure that you want to image. Oh yeah, focus, we haven't had a look at that. Let me just show you that. So the focal zone is a specific row again that you want the machine to focus on, and there's again, it's different for every machine. My one's got a little arrow on the side. On the depth here, I'll zoom in a minute and you'll see it just on there. There's like a little red arrow just there. You see that? That's where I'm asking the machine to focus on, is 2 centimeter depth, but I can change the focus and I can push it up and down. So you can see the arrow move as I see it there, and there it's going up. What it will do is it will change the focus of the machine so it's higher or lower. If you change the depth, the time gain compensation, and the focal zone to the specific area that you want to target, you're going to get a really good image. Those are your key things. Focus and then the overall gain. Let's just have a quick go at this. I'll go through this really quickly and then I'll show you an example of how you can scan things. Bone, we said this before, bone should be really bright. This is the biceps tendon in the bicipital groove. This is the humerus. There's the tendon there. This is a cross-sectional view of the tendon. It looks like a fiber optic cable. If you imagine all those little myofibrils coming up and it's a cross-section across, that's what you can see on the biceps when you scan it. And the bone is really bright. This tissue over the top is muscle tissue because it's all speckledy. Yeah, you can see those striations in the muscle as well. That's what bone looks like. Cartilage looks quite grey. Yeah, it's not as bright as bone. This is a knee, the top view of a knee. You've got that groove where the patella sits, and then the condyles either side. The cartilage is quite grey. This is a nice one of muscle. So you've got skin at the top, subcutaneous fat, which is that globular structure, then the kind of speckledy muscle. So this will be rectus femoris. Vastus intermedius underneath that. You can see the fascial lines that wrap around those muscles and segregate them all. And the good thing with ultrasound is you can then do flexion and extension and you can see these muscles move and you can see the tissue glide across each other. And then we've got the femur underneath. And because it's quite deep in the quad, the bone isn't as bright as if it was superficial because it's trying hard to get the image back. Tendons look like this. This is the Achilles. They look really, really stripy. And then there's the calcaneus, there's the bone, and then there's Kager's fat pad underneath. There's the globular fat tissue underneath. And then underneath that, you've got flexor hallucis longus, which you can see really, really clearly. That's a cross-sectional view of the Achilles. That's what we call a long view, so longitudinal, and then that's a short view or cross-sectional. And then this is the anisotropy again. You can see the tendon really well here, but because the tendon's curved, if you've got the probe in one direction, if the tendon's curved underneath, you're going to get a really good image of some bits of it, but then the other bits, because they're curved, they're going to bounce and then ping off in a different direction. You need to maneuver the probe around so that it then runs perpendicular to the other bit of the tendon so you can see that a bit more clearly. But that's what you'll see. And the problem is with that is you'll think that there's a tear there, but it is literally just the alignment because of the tendon curve. And then ligaments, they look stripy. They're like this. Yeah, they're a bit different to tendons because they're stripy too, but ligaments are brighter because of the collagenous tissue. They look a lot brighter than tendons. I'll show you how to scan an Achilles. This is a lovely young Achilles. This is my daughter who volunteered to be examined here. There's the Achilles, pop the ultrasound gel on. There's the calcaneus just there. That's on the right hand side of my probe. And then there's the Achilles tendon just there. First thing I would do is line up that Achilles, but my depth was too deep. And now I'm going to change my depth and then rescan it. And look how much brighter that is. Much, much better image because now the ultrasound machine is being asked to work in that top section. Just changing the gain slightly. And there we go, look at that. So you can see the difference that you can make just by doing a couple of tweaks. But there's the tendon there. Nice, healthy tendon of a 17-year-old. Wish my tendons were like that. Okay, and you can follow it all the way along. And then eventually it will start to turn into muscle tissue because it will turn into the gastrocnemius if you keep going. That's the tendon on the top. And you can see actually there was a couple of bits where it like there, where it went black. And that's because there wasn't any ultrasound gel on that particular spot. That's a long view. And then if we spin it, I think I spin it on this one, you can see a cross-sectional view as well. Let me just rewind that a sec. So there's your Achilles across the top. There's Kager's fat pad underneath. And what I'll do in a sec is I'll get her to wiggle her big toe because flexor hallucis longus is underneath the fat pad. So there's the fat pad just there. And then there's flexor hallucis. But if I get her to wiggle her toe, can you see that moving? Yeah, you can tell which structure's which. You can get them to move stuff and look at it there. She's wiggling her big toe, but nothing else is moving, just flexor hallucis. And that sits deep to Kager's and then underneath soleus as well. Yeah, that's a really nice demonstration of how you can see the different structures sliding across each other. And it's a nice satisfying one to start with that because it's quite easy to see. And the good thing is with that scan is you've got bone, tendon, fat, muscle. You've got pretty much everything all in that space and you can differentiate between everything. Right, I'll do one more. I'll just show you the medial knee because I think that one would be a good one to see the differences with the ligamentous tissue. My son this time got roped into this one. This is a slightly older knee than my daughter, only a little bit older. But you can see, there we go. There's the bone. And then there's the knee joint just there. Let me just pause that there. This image here, this is one from the ESSR. They've produced lots of documents to show you how to scan. And so we've got the femur and then we've got the tibia down there. There's my son's tibia. There's his femur just there. In between there, in that space there, that's where the meniscus is. You can see the medial meniscus on this image as well. And it looks, when you get the angle right, it looks like a Trivial Pursuit wedge. It's like a triangular wedge. If there's any problems with it, there might be tears in it or it'll look irregular, or there might be fluid coming out of the joint as well. But that structure there on the top, that's the MCL, which is here on that image there. So I'll just play that through. There's the middle of the joint. There's the MCL just there. That's where the meniscus is just there. And if I play around with the angle, so if I tilt it, then you can, there it is there. Okay, so you've got it, and this is what I mean by playing around with the tilt. Yeah, on that very first slide from the BGSM. So play around with the different angles, and then different tissue will then highlight on your imaging. Cool. Should we do one more? We'll do patella tendon really quick. This is a nice, easy one to scan as well. And again, I want to get the end of my probe on the inferior pole of the patella, the apex of the patella. So I'll shove a bit of gel on. And again, this should be a nice young knee. So there you go. There's the patella. There's the patella tendon just there. Underneath there will be Hoffer's fat pad this time. And then if you follow the tendon down, then you'll get it joining into the tibial tuberosity. If there's any problems with that, you can see thickening. You can put Doppler on it, and there may be Doppler activity if there's inflammation there, especially in the fat pad. That's a good one to check. And then that's a cross-sectional view of the tendon as well. If I just go there, I'll just wait until I spin it. Okay, and cross-sectional, it will look like this. So here we go. I think I'm just about to spin it. Yeah, here we go. And that's it there. Up into the patella. And then as I scan down, there it is there. And I can scan all the way over it side to side, so I can see the full extent of it. And again, I can have a look to see if there's any tears in a short view as well as a long view, because sometimes it's a bit easier to see in one view compared to the other. If you had something like Osgood-Schlatters, then you definitely see some changes on the tibial tuberosity as well, and you'd be able to see them really easily. Done. Sorry, going on for 50 minutes.
Mate, honestly, thank you very much, pal.
Welcome.